I'm Alex Bakenga. I'm a first year M.Med. 1 internal medicine, and I'm presenting the first case. So the demographics, I'm presenting SA, a 39-year-old, a Protestant, was staying in Bunamwaya in Kampala. The next of kin was the wife, and this patient was admitted on the 14th of April 2014 on the STC ward in Cancer Institute. STC is a solid treatment center, and it was on the private wing. So his presenting complaint at that time was abdominal pain for 9 months and vomiting for 8 months. In the history of presenting complaints, he was a known patient living with HIV/AIDS since 2010, and he had been maintained on septrin prophylaxis and atripla. He was a referral from Cardiac Medical Center in Kampala with a 9-month history of progressive swelling of the upper abdomen associated with colic abdominal pain, early satiety, and postprandial emesis associated with hematemesis, melena stools, and during time he was being managed as a case of peptic ulcer disease. In February 2014, he went to Nakasero Hospital where they did an upper GI endoscopy and biopsy in the same sitting. And this revealed a histology of adenocarcinoma of the stomach. He was later transferred to the radiotherapy unit in Mulago Hospital, and he confesses that the swelling never reduced in size. How it just continued to increase in size. However, there was pain relief. 1 month later, he again was having postprandial emesis. He reported a history of weight loss, poor appetite, evening fevers, and drenching night sweats. In April 2014, he had an abdominal CT scan done. This revealed multiple intra-abdominal masses involving the liver, and the CEA was done at that time, and it was 1,000. CEA is a carcinoembryonic antigen, and that's why he was referred to the UCI for further management. In the review of systems, it was unremarkable. There was nothing much to report. In the past medical history, like I said, he was HIV seropositive, maintained on septrin prophylaxis and ART since 2010. The CD4, the record of the CD4 we had was 339, and that was in January 2014. We weren't able to capture the baseline before he started ART, and he was attending the JCRC in Mengo. There was no relevant OI history to report about. And he was non-diabetic, he wasn't hypertensive. In the family social history, he was a transport officer at Nature Uganda, monogamously married with 2 children, the first one being 5 years and the last one being 9 months. The wife was into business and they were discordant. He was a heavy alcoholic and he used to consume whiskey, beers, and spirits. However, there was no history of tobacco use, and there was no history of cancer in the family. He confessed to missing his children, and he wanted them to come and see him once he was strong, because at that time he was bedridden, and he didn't want them to see him in that state. His main concerns were the persistent vomiting he was having, and yet he had no much pain on swallowing. He continued to have some breakthrough pains despite the morphine, and he continued to get worse, being bedbound and immobile. He said he could no longer have energy to move out of bed than he was able to do before. However, he hoped the pain would go away and it gets better so that he can get out of hospital. He was also hopeful that given time, he would be strong, have a full life like he had before. He was a hopeful man because he was believing in God, and his faith kept him going and kept him strong. He also wanted to go to India for surgery, and he was lucky that the family was supportive. So in the general exam, at that time he was sick looking, he was unwell, He was cachectic with prominent bone prominences. He was afebrile. He was dehydrated with dry mucous membranes. He had pallor of the mucous membranes. He had no jaundice. I think that's just a repetition. He had no lymphadenopathy. He had dependent pedal edema in the lower limbs. He was bedbound with a performance score of 4 on ECOG. And his BMI was 15.43 kilograms per centimeter. Systemic exam, the abdomen, it was distended, it was moving with respiration. He had a hepatomegaly extending up to the umbilicus. It was hard, firm, tender, and it had a coarse texture. He had no ascites. Bowel sounds were hard at that time. In the cardiovascular system, he had a pulse rate of 75 beats per minute. It was regular, but it was reduced volume. The blood pressure was marked low, like you can see. It was 56 out of 42. However, heart sounds 1 and 2 were hard, and I wasn't able to appreciate any heart sounds. In the chest, he wasn't in overt distress. He had a respiratory rate of 20 breaths per minute. He was saturating at 95% on room air, and the chest was clear. In the CNS, this patient was fully conscious. He was oriented in time, place, and person. He had no meningeal signs. He had no overt craniopathies, and he had no overt focal neurological deficits or fallouts. The investigations we had, I was able to capture 2, like maybe some of you don't know. This patient had been at the Cancer Institute since the 14th, so the CBCs are done twice weekly, and there were so many. So I was able to get the one at admission and the one which was the most recent. Significantly, maybe on the 24th of November, he had a profound neutropenia and a thrombocytopenia, but the hemoglobins were within normal range. The other labs, his hepatitis C and B were negative. His ESR was raised, was 35. His random blood sugar was 4.9, which was normal, and his CRP protein was raised, was 56. The CD4, like I said before, it was 339, and the viral load was undetectable, but that was in March this year. The chemistry, significantly, what we can report about was the ALP, which was raised, which was 257, and the GGT, which was 239. His albumin was within normal range. It was 3.6, and his renal functions were normal. His CEA was markedly raised. It was 1,226. The imaging, his chest X-ray was normal. The abdominal scan, the radiologist reported cancer of the stomach with extensive metastatic mental disease, bilateral chronic pyelonephritis, and a hepatomegaly. The abdominal CT reported liver cirrhosis with chronic pancreatitis. However, he had no enlarged lymph nodes. They didn't comment about the liver. The EKG and echo were normal.